Just ahead on this edition of Being Well, we've got a specialist in the studio. Dr. Arturo Menchaca from Paris Community Hospital Family Medical Center is a urogynecologist. We'll be learning more about this area of medicine and the types of cases that he treats, including incontinence, fibroids, and others. It's an interesting 30 minutes just ahead, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston. Today we're talking about women's health issues with Dr. Menchaca from Paris Community Hospital Family Medical Center. Welcome to Being Well.
Oh, thank you, Larry. It's a pleasure meeting all of you here. It's a nice town. I heard about Eastern Illinois for a long time, but this is the first time that I've been here.
Well, tell us a little bit about your background, because you have a unique subspecialty that a lot of people have never heard of.
What you're talking about is the subspecialty of urogynecology. Mm-hmm. We have specialties. Once we finish medical school, we do a residency, and that's called a specialty. And now I went through obstetrics and gynecology, did 4 years of that. And then I did a subspecialty on top of that, which is urogynecology. Mm-hmm. I did this in 1988. That's when I finished, so it's been a little while. I'm dating myself here. But nevertheless, I've been in practice for this long. It's now 27 years that I've been doing urogynecology. I've been working in Chicago since I graduated. The hospital that I've been with, LaGrange Hospital in Hinsdale, they recruited me when I was a fellow doing the subspecialty.
All right, and then you actually went to the U of I for a little bit in Urbana.
Oh, yes. Yes, I went to U of I. I'm totally familiar with U of I. I mean, I didn't get to party as much as other people because I was in medical school there, and then I went to the medical center in Chicago, and that's where I did all my rotations, my clinical rotations. Mm-hmm.
And then how long have you been at Paris Community Hospital?
I am totally brand new. I just came on board about 2 months ago.
Okay.
Yeah, so I'm liking it. It's a nice little town. I love the people there. I mean, that's one of the main reasons that I came down here. Mm-hmm. I came to interview, and I love the people that I talk to.
Well, let's talk a little bit about what your subspecialty covers. We know it covers some of the typical things that OB and GYNs do, but you go a little bit further.
Yeah, I mean, as you said, I cover general OB/GYN. Well, I don't do any obstetrics. I don't see any pregnant ladies.
Okay.
I don't do any birthing or any of that. But I do the gynecology, and I specialize in minimally invasive surgery. That's one of the specialties that I have. And minimally invasive surgery is trying to treat major problems or any problem that you have in a minimally invasive way. If you have fibroids, pelvic pain, endometriosis, ovarian cysts, ovarian problems, then finding the way of doing the treatment in the least invasive way of doing it. Mm-hmm. And then on top of that, I do have the urogynecology, which also treats minimally invasive ways of doing things, but it concentrates on the pelvic floor, starting from the front to the back. Mm-hmm. So problems with the bladder, of course, being unable to urinate, urinary incontinence, any frequent urinary tract infections, blood in the urine, those type of things with the bladder. Then in the mid portion, dealing with the pelvic organs of the female. I don't deal with men at all. Mm-hmm. This is just a specialty for females. Okay. And I deal with prolapses or hernias that come from the pelvic organs down through the vagina and possibly even coming out of the vagina. Mm-hmm. So we're talking about prolapse of the bladder, prolapse of the uterus, prolapse of the intestines, and prolapse of the rectum. There's certain symptoms that you have. You can have retention, you can have incontinence, you can have frequent urinary tract infections, you can have abnormal bleeding, ulceration of the cervix, ulceration of the vagina because of the prolapses are coming out, fecal incontinence also if the problem is in the posterior part of the pelvis. So the specialty is known as female pelvic medicine and reconstruction. That's the official name of the urogynecology. It used to be known as urogynecology and pelvic reconstruction, and they changed the name a little bit because we deal with not just surgical problems, but also medical problems of the pelvic floor.
When you're talking about minimally invasive, I mean, how has that changed for women in types? Let's talk about like hysterectomies. How has that changed the field and what women can expect if they don't have to have the traditional open surgery?
I came at a time, this is a very exciting time that I came into the practice. About the time that I came into, there was the beginning of laparoscopic surgery. And even up until the recent past, about 6-7 years ago, when the robotic surgery came into the market, there were few surgeons that were able to do advanced laparoscopy. Most of the time you will have a large opening. If you had large fibroids, they would open the abdomen and take out the uterus, the fibroids, and then the recuperation would be weeks. And by using advanced laparoscopy and now robotic surgery with the Da Vinci, you can do minimally invasive surgery that you can almost go to home after that the same day. And the recuperation time is in days instead of weeks. So that's what we're looking at, trying to reduce the pain, trying to reduce the discomfort, and trying to get the patient back to doing what they're used to doing in the least time available.
It's much easier to recover from a small incision than from a very large one.
We're doing like 1/4-inch incisions rather than large incisions, and those are, of course, beneficial to the patient.
I had a question one of my girlfriends wanted me to ask, and she asked, are you seeing more women for the treatment of heavy, uncomfortable periods? Are you seeing more of that, or is that there are just more options for treating that than there were 20 years ago?
It's a combination of things. It's a good observation that your friend had. Nowadays, since we're doing minimally invasive procedures to treat major problems, we're not doing a hysterectomy.
Right.
So you leave the organ there, and in the future, you may have other problems with the organ. So you're doing more minimally invasive problems rather than using a shotgun and killing everything in the pelvis. And the other issue, I think, is what is happening in society. I think that the way that people are eating, is fast food. It's a fast life, fast food. People are eating more calories. So gradually, if you look at the statistics, gradually people are becoming a little bit more overweight than we used to be 10, 15, 20 years ago. When you become overweight, you change hormones, and the hormonal changes that happen are going to give you problems, either with bleeding or with fibroids or, of course, pelvic pain, more descent of the pelvic organs just because you have more weight on top of the pelvis. So weight does have a lot of influence in what's happening. There's people getting more diabetes, more hypertension, higher lipids, high cholesterol, and all those things not only affect the hormones, but the way it affects the pelvis and the abdomen in total.
So some of our lifestyle is contributing to some of these other problems. When do you decide, can any surgery be done minimally invasive? When do you go, well, we can't do it this way, and we have to do it the traditional way?
My philosophy, first of all, is to do minimally invasive procedures. So if there is not a way, then I try to figure a way how to do it. And that's the basic thing. I mean, I figure which way would I want the surgery to be done. I want to get back to normal activity as soon as possible. So how can I do this so that I get back to that? And that's my philosophy, first of all. So I kind of have taken classes, going to conferences, doing everything possible so that I can learn that way of doing it. And the way that I tell people that are not doing minimally invasive, I always ask them the question, well, if you had to do, if you needed a tonsillectomy done, which way would you want it done? Through the mouth or through nice little incisions in the neck? Without exception, they tell me I want it done through the mouth. Well, the same thing in females. If you need something done in the pelvis, if you already have the opening there, which is of course the vagina, why go through the abdomen?
Right.
You know, even if it's small incisions through the abdomen, laparoscopy or robotic, why go through the abdomen if you can do it through the vagina, which is available there? And that's the way that I do. So initially, what I want to do is do the procedure through the vagina, and then if not able to do, help myself with laparoscopy. And then if not able to plain laparoscopy, use the robot. And that would be the last thing. And finally, if it cannot be done with the robot, then open the patient.
So do you know like what percentage or have an idea of, are you doing far more minimally invasive?
Probably in the last year, I have maybe done 1 or 2 abdominal hysterectomies, open. Probably 1 in the last year out of I don't know, many that I've done. Most of them are done vaginally and then laparoscopically and robotically. It's even large fibroids that are like the size of a 5-month pregnancy up to the belly button. I'm able to do them vaginally. Okay.
Which I would imagine the recovery time is far less versus having the open
definitely.
incision.
Definitely a lot quicker. I mean, you're eating the same day, you're ambulating the next morning, you go home the next day. And if you have a large incision, that takes, like I said, weeks to recover from that.
I want to talk about a problem that's embarrassing for several women, and that's incontinence. And we seem to see on television more advertisements for incontinence products, but also lawsuits for something called pelvic mesh. I want you to talk about that.
Well, the problem of incontinence, it's a common problem, and I think men don't realize how common it is, even more than women do. Women, there's a lot of them tend to think that it's a normal part of aging or normal part after having babies. Incontinence is not normal. Okay. It's a problem. So first of all, I like to let your viewers know that it's not normal and you can do something about it. So you have to seek somebody that treats that problem so that you can live your life a normal way. You don't want to start limiting your life. Stop going to parties, stop dancing, stop exercising, playing golf, or whatever you like doing because of the problem. And you shouldn't have to be buying pads and wearing them every day just because you don't have something done about it. So there are people that specialize in treating incontinence. So it's a very frequent problem. One of the main culprits is having babies. So whether you have the problem, and each one of us is involved in that problem. Whether you have the problem, of course, it's a personal problem, but all of us were birthed at some time by a female. So we were involved in causing incontinence at some time.
It's an interesting way of looking at it.
Okay, so everybody's a culprit in this issue, and we should be concerned about it because it's a normal part of humanity. So when babies are born, the baby's head, of course, is 10 centimeters. You know, it's a big head to come through a limited space. And when babies come out, they tend to damage the organs in the pelvis and the vagina. And gradually, I mean, there's times when we have to do C-sections because the babies just don't fit through the vagina. And at other times when they do fit, we have to use either the vacuum or forceps. And when babies come out, there may be some tearing of the tissue. You may not have the immediate results of the damage, but gradually those tears start opening up and eventually they show up. And definitely when women go through menopause, that's when you have the big change because estrogen really weakens the tissue. The collagen in the pelvis, not only in the pelvis, but everywhere in your body is dependent on estrogen. And once you lose the estrogen during menopause, then everything starts thinning out. If you look at movie stars before menopause and after menopause, 5 years after, you will see the change in their face. Well, not only does it happen in the face, but also in the pelvis. and everything starts weakening there, and that's when you start having problems. The problem might be a minimal amount, or it may be a major problem. You can treat it by doing something simple as Kegels, or you may need something like a sling, which is made out of mesh. And that's what you're talking about with the mesh issue. Well, we use mesh. It's a synthetic product, but it has proven we started using mesh about 17 years ago for incontinence, and we have had very good results. About 7 or 8 years ago, we started using it for pelvic organ prolapse reconstruction. That's when we started having some problems. The companies train all the OB-GYNs and train all the urologists in the usage, but not all the surgeons had the expertise to use the mesh and doing the big reconstructive procedures that are needed to do that. So there were some issues, but the FDA gave a warning about 5-6 years ago about the mesh, and I think that some of the lawyers took off with that and started, of course, putting a lot of advertisement about that. But the mesh, I still use a lot of mesh. If you don't use mesh for large problems, then the problem will come down again. And then you have to redo the surgery all over again. So what we use is something called graft, or we use mesh so that we can buttress the repair so that it doesn't come down again. Of course, there are things that we may need to do prior to the surgery so that we have good tissue. During the surgery, our technique is paramount, and then afterwards, we have to impress upon the patient that it's very important to take care of the reconstruction, or she may bring the thing down again if she doesn't follow instructions. So it's a combined effort between the surgeon and the patient.
When you're talking about, I want to backtrack a little bit. When you're talking about incontinence, you said it's not normal, but when should someone see their doctor about incontinence?
I think that sometimes incontinence can cause obvious problems. If you're always wet and you're always wearing a pad, you're probably going to have some rash, you may have fungus, you may have something else that may force you to see a doctor immediately. But if you don't have that pressure, a lot of women go around with incontinence for many, many years. So it's not a necessity that you see, but once it starts interfering with your life, then I think you probably should see a doctor. There was a teacher, she was 27, 28 years of age, she was a dance teacher, and of course, she's always in leotards, she's always jumping around, and she can't be wearing pads with her leotard and losing urine. So of course, she's going to, this part of her life. So of course, she's going to see somebody sooner than somebody that doesn't have that type of activity.
So an occasional, you jump up and down or you laugh a little bit, that's okay.
Yeah, I guess it might be okay if you can tolerate that. Well, that might be fine. If you cannot tolerate it, like, you should see somebody. You know, it may be something as simple as you doing Kegel exercises, and I'm sure most women have heard about Kegel exercises for one reason or another. Definitely, moms have heard of Kegel exercises because they teach them right after you have a baby. They teach you how to do them, and just by doing those, they can be of benefit to get rid of the incontinence.
Is there anything other than, you said because we were all born, we kind of contributed to the problem, but is there anything you can do to prevent the incontinence issues in the first place, or is it just?
Well, the first thing is, I guess, genetics you cannot change.
Right.
Having babies, well, you can change that. Not having any babies, because if you have a baby and you deliver vaginally, you are running the risk of having a problem, and you can't do anything about that. So once you have the problem, then I think you can do the Kegel exercises. Make sure that you don't gain a lot of weight. The exercises that you do, don't start lifting 200, 300 pounds. Don't become a super weightlifter. Paratroopers, actually, there was a study where paratroopers were getting incontinence, and these are young ladies, the 20s, early 20s, and just by jumping out of planes, they were getting incontinence. So certain jobs do have that type of factor included into whether you become incontinent or not.
So keeping your weight down. Not jumping out of airplanes.
Not jumping out of airplanes, right? not becoming an Olympic weightlifter. Things like that can help. If you are a healthy person and you are going through menopause, you might be a candidate for hormone replacement therapy. And taking estrogen and progesterone, they will keep the collagen intact for a longer period of time. So if you're going through menopause, make sure that you're not a smoker, make sure that you don't have any cardiovascular problems, and of course that you don't make that decision at the time when you're going through menopause. The decision to become a healthy person comes throughout your lifetime. You have to eat healthy, you have to do the right exercises, and by the time that you go through menopause, then you're a healthy patient and you have the option of taking hormones so that you keep staying healthy.
I think one of the other things we hear a lot about that causes problems for women are uterine fibroid tumors. Causes pain and heavy bleeding. What are the treatment options for something like that?
Fibroids are very common. 40% of women at the age of 40 have fibroids, so that's a large percentage. Now, you don't hear all your friends having surgery for them because most of the time fibroids don't cause a problem. By themselves, they will not turn into cancer. Probably 1 out of every 500 patients will have the possibility of a fibroid turning into cancer, probably even less than that. So the percentage is very minuscule. And if you don't have it in a place where it will cause a problem, you don't have to do anything about it. Once you go through menopause, then you will decrease the estrogen, which is the hormone that feeds the fibroids, and then the fibroids will start getting smaller. Now, occasionally you do have fibroids that cause problems. If they're inside the uterus or right underneath the lining of the uterus, then you may have heavy bleeding. And that's when you may want to seek a doctor, because if you bleed a lot, you will be anemic and you'll be tired every day. You'll be drinking 6 cups of coffee and then not being able to sleep because you're drinking so much, and all because you have anemia secondary to the bleeding because of the fibroids. So in that case, you do have to take care of the problem. And the minimally invasive ways they were talking about is either laparoscopy, which is you make a little incision in the belly button, and then you look with a microscope that's the size of a pen. You look inside like
Get
this.
The pen right there.
So you put it through the belly button, you look inside, you figure out what you have, and then through other little incisions, you can do the surgery. If it's inside the uterus, you can go through the vagina, use what we call a hysteroscope, so you can do a hysteroscopy, and you can do a polypectomy if it's a polyp, or a myomectomy, which is taking out the fibroid. And then on top of that, we can do an ablation, which is burning the cavity of the uterus, not through and through, of course. It's a limited ablation, a limited burning and thinning out of the endometrium, and they will take care of the heavy bleeding. Probably about 40% of women will not bleed again, and then the rest will bleed minimally when they have a period.
What we're kind of wrapping our conversation up. What sort of advice would you give for women who are having some of these issues? Maybe it's incontinence or heavy bleeding and a lot of problems, and they're like, "Oh, I don't know. Maybe it's just me. I can live with it." What would you say?
Well, I think you should talk to your primary care physician. He may be able to help you with what is happening. It may be a minimal thing. If you're in the younger age group, it might be some irregularities, hormonal irregularities that can be fixed with just taking the pill. If you're in
birth control pill?
The birth control pill. There's also ways that you can control that with putting an IUD that has progesterone that's called a Mirena. Now they're coming in with Nexplanon, which is an implant that you put into the inside of the arm under the skin, which can also help abnormal bleeding. So there's ways that you can deal with that. But if you have a question, you probably should seek out your primary care physician. If he does not know what is happening, then he will send you to somebody like an OB-GYN that has the expertise in that. And of course, if the OB-GYN does not have the expertise in minimally invasive surgery and requires more expertise, then they might send you to somebody like me, which has the expertise in doing advanced laparoscopy, advanced hysteroscopy, even robotic surgery, which I do for problems like this.
Well, it sounds like there are now so many more options for women to seek treatment in a variety of gynecological areas.
Oh, definitely.
That they don't have to suffer with that sort of
Definitely,
stuff
and
anymore.
that's what we want to do. We want to advance medicine so that we can enjoy what we're doing, and when we do need to have surgery, so that it puts us back into what we're doing in the least amount of time.
Well, Dr. Menchaca, we're all out of time. We would love to have you come back on the show again, because I know a lot of our women viewers have lots of questions that they would like answered.
It's a pleasure being here, and if there's questions, please have them call me, or if you want me to come back, I'll be happy to. If you have a list of questions that your viewers have already sent you, I'll be happy and answer them.
Wonderful. Thank you so much for coming to Being Well, and welcome to Central Illinois.
Oh, thank you. It's a pleasure, and I'm really loving it here.
Good.
Being Well is also available online at our YouTube channel, youtube.com/WEIUTV. Just look for the Being Well playlist. Here you can view current as well as past episodes. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Alpha Care, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. Alpha Care, compassionate professional home care. Additional funding by Jazzercise of Charleston.